I'm Lucy. I have worked for Evolve Care at Henton Nursing Home for almost 5 years now. My background was actually in sort of palliative and complex nursing. I did a decade in a complex nursing unit, and then felt I needed a change, and Henton is where I've stayed ever since, really. Yeah, so learnt lots of new skills. I love my job, love teaching, even when I'm coerced. So yeah, so we're just going to basically talk about real basic stuff today, but it's basically the backbone of everything. So basic skincare and wound management. Like Anne said, any questions, pop them in the chat bar. I can't see if anybody puts their hands up or anything. So basically, we're going to discuss why basic skincare is so important. So as we get old, as we all know, our skin changes and undergoes very significant changes. We notice in the people we look after, it becomes thinner, drier, more fragile. We don't produce collagen or elastin in the same way when we get to a certain age. I'm sure you guys have all seen it in wherever you're working in your sectors. People bruise easier, more skin tears. Even just holding someone's hand or scratching their arm, they can cause damage. And that basically means that the skin can no longer act as the protective barrier that it was meant for. So in our younger days, we could fall over and get back up and bounce and off we go. As we get older, obviously that's not quite so good anymore. So basically, why do we talk about good basic skincare? Well, it's a myriad of things, really. It can help prevent infections, stop wounds, pain, also an everyday useful tool. So, how many times has a care assistant gone to do personal care, come back to you and said, oh, something's not quite right there, this doesn't look right. It just means we're then able to find things, discover things, such as, there's a lot of things, but main ones like skin cancers, circulatory problems, discoloration, and fluid retention, swollen limbs. So the risks. So I work in a care home with very severely cognitively impaired people, mostly dementia, some mental health. Majority are elderly. So we are presented every day with quite a lot of challenges. Resistance or distress. People when they're cognitive challenged, they just don't understand why they need to go and have a shower. In their mind, they've already had a shower that morning. Staff might rush washes and showers. If somebody's being particularly challenging, it might just be thought, let's just crack on, we'll get this done as quick as possible. Poor tolerance of hand washing. It's drummed into all of us, wash your hands, wash your hands, wash your hands. How many times can we honestly turn around and say that the people we care for, that we could, honestly say that person's washed their hands really thoroughly like we're taught to? Reduced ability to communicate if they're itching or uncomfortable. Certainly, with dementia patients, cognitively impaired, what they truly are feeling is often displayed differently. That can be through anger, emotion, agitation. Incontinence. I'm sure the majority of people we look after suffer at some point with, being incontinent of urine and feces. That against the skin, unfortunately, is going to potentially cause damage. Increased sweating. So this can be for a myriad of reasons. Again, people wear multiple layers. They might sit in very hot environments. Being overweight and skin folds. So, we're talking sort of belly flaps, underneath female breasts, even for men between genital areas, between leg and testicles can be a difficult area. And being overweight, more and more, unfortunately, our general population, we see it across the news every single day that we are a generation that is going to become more overweight. Certainly, we've seen more overweight people coming into the care sector. It's going to have a long-lasting effect. Inappropriate clothing fabrics, certainly today, in today's sort of, quick fashion market, not many clothes are made out of cotton or natural materials. It's polyesters, which are not great, can cause issues. Incorrect use of build-upper creams, where you apply your creams first thing in the morning, and then at lunchtime you think to apply more. Can we honestly again just say, well, actually we're washing that person first and we're washing off previous creams. We do quite often see creams building up in areas. Prolonged contact with sweat bedding or clothing. So if someone's in bed 24 hours a day, they might be bedbound, for example. How often is their bedding changed? They also tend to lie on mattresses that, again, aren't of a natural material for a long time. Environmental risks that person can't control. Heating is a big one, temperature changes, temperature fluctuations, and it's always difficult in care homes because the people we look after, the majority of the time they might be sat down, they'll probably feel the cold, whereas care staff are up and running about. We get hot and we get bothered and we might open the window and then the people sat down are suddenly very cold. So it's not just about hot temperatures, it can also be about cold. Illness and disease. So again, unfortunately, as we get older, we're more prone to illness and disease, and there are certain illnesses and diseases that go hand in hand with issues with the skin. And again, increased frailty as we get older. That has a knock-on effect, increased frailty with all sorts, blood circulation, not moving around as much, as well as your cognitive ability, and an increased risk in falls. And again, when you're young and you fall over, you get back up, you bounce, and off you go with your life. When you're older and you fall, it can have much longer lasting consequences. And reduced appetite. If people aren't getting a well-balanced, nutritious diet, they're not getting the protein they need to help their skin repair, then obviously that skin is going to be damaged for more prolonged periods. So, what specific challenges do we face in our care homes? So, we've already talked about various risks and things that can happen. Are there any more specific ones? So, compliance. So, a huge factor. I'm sure all of you have come across people that are cognitively impaired. A lot of you probably work in homes and places where this is. So what do we mean by compliance? A lack of understanding. That person might not truly understand what their care needs actually are. They may misunderstand your intentions. You might have all the best intentions in the world with that person, but if they can't understand that, they could feel like you're trying to steal them away or lock them away, or why do two people want to suddenly undress me and stick me under a shower? And I don't, they don't understand that. Incontinence is a big issue, obviously. Yes, we have incontinence products. Sadly, most incontinence products are coated on the back of them with a plastic, and if people aren't using these continence products correctly, then unfortunately there could be issues with sweat because of that. They also, on the plus side, have a good, they are for a good reason. They will wick the urine away from the person, but people might not want to wear them. Certainly I've known people that think, oh god, no, it's a nappy, I can't wear a nappy, it's going to look terrible. I don't want to wear that, and then they become wet, they pass feces, and that just sits against the skin. And also supply of continence pads. If you work in a care home, you're probably all quite well aware that actually we only get a limited number of continence pads per 24 hours, and that's out of anybody's control. So that can be a massive issue. People might go through them quicker. Choosing the correct clothing. So quite often, people will wear, I'm sure we've all known people that in the depths of winter will still wear shorts, even though it's -5 outside and snowing. It's, they feel they're warm, so they want to wear shorts, and they're quite happy with that. As we mentioned before, cotton clothing can be very hard to come by. It tends to be more expensive as well, natural clothing. And the big one really with people that suffer with dementia and other cognitive difficulties is that sequencing becomes an issue. So you might find they've got 4 pairs of pants on and 3 t-shirts and a jumper and a pair of shorts and a pair of trousers, or 2 pairs of socks, or 2 pairs of socks on one foot and none on the other foot. And then reduced mobility, so people can become less mobile. People can change very suddenly with infection. If somebody has an infection, it can knock them off their feet for a little while, and they suddenly go from being very mobile to not mobile. And in old age, it's very, very, people's skin can break down very quickly. And long-term use of medications. So the biggest one that we're probably all well aware of is the use of steroids. Steroids do thin the skin, and obviously then that's going to increase the risk of skin damage occurring, unfortunately. So moving on, what is good basic skincare and what does it involve? It's actually quite simple, yet quite challenging at the same time with the environments that we work in. So good washing and drying of a person's skin and regular washing throughout the day. Sounds simple, and we all know in reality that actually, with time pressures, staff pressures, the pressures of the people you look after, that can be quite a challenge. Good routine continence care, as we've said, so using the correct equipment, the correct pads for that person, making sure they've got the correct like we call them net knickers, making sure they're the right size, because there's no point having the right pad and then the thing you use to hold it in place doesn't fit because the pad will just move. So movement. So, as and when people can get them up and moving about, obviously people are going to be not mobile. So in that case, regular repositioning is absolutely crucial. You're offloading pressure, ensuring that, they're not lying on one side too long, regular moving around. Essential skin hydration. We will come to this a little bit further on, but making sure that skin is well moisturized on a daily basis. And a good, well-balanced and nutritious diet. We've touched on this before, but yeah, I mean, absolutely every single, food category you need, then we need to make sure we're offering that on a daily basis to people. So what are the 5 most common types of wounds we see in a care home setting? I'm pretty certain all of you that are on this call today will have seen all of these at some point in your working lives. You've probably seen some of it today, some of you. So a big one is moisture damage, tends to be groins, sacrums, tummy fold, under breasts. You can see the picture there is actually moisture damage to a female's breasts. Obviously with moisture damage, it can be personal care itself can be a challenge. So if you've got somebody that really struggles with personal care, you cannot take your time. You're not able to explain to that person because they don't understand, why you need to lift their breasts or their tummy flaps or move their testicles out of the way, then that, getting to those areas of moisture will always be a challenge. Bruises. So people tend to have decreased awareness for their environment. So you'll notice people will bump into furniture or bump into doors or walls, or, they'll just knock into things more than normal. And dare I say, because it needs to be mentioned, but poor moving and handling. We as a care homes, we need to be very mindful of our moving and handling techniques. And when we do get bruises, we have to have the ability to be able to look and really study those bruises and say, well, actually, is this an environmental issue, or is it down to poor moving and handling? Skin tears or lacerations. Certainly, I'm sure we've all seen plenty of skin tears in our time. People, again, when they knock into things, the skin becomes so frail, and it can start out as a bruise and then become a skin tear. If somebody was to scratch or knock that bruise again, it can just damage that layer of skin. And rashes. More commonly because of in homes due to dramatic changes in temperature. So central heating in itself is a very drying thing. And certainly as we go into winter, we tend to put the heating on, and homes can become very hot environments, and that can irritate the skin. And the last one, which is a big one, pressure damage. So yeah, I mean, I'm sure we will go through that a little bit later, but yeah, pressure damage is a massive one. Not always obviously acquired in care homes. It can be acquired in the community, in hospital, wherever. So we talked about moisturizing skin. So basically every single person living in a care home environment should have access to a moisturizer. This should be on prescription. and can be used for a multitude of sins. So you can use it as a soap substitute. So many shower gels and soaps these days are scented, perfumed. They've got ingredients in that can irritate the skin. You know, things like Epimax, double base, they are absolutely brilliant to be able to use as a soap substitute. And it's a double whammy because as you're washing the person, you're also applying that moisturizer to the skin and hopefully locking in some of that moisture. And yeah, it just eliminates the use of shower gels that can be irritating. And barrier creams, you know, when I first started nursing, it was all about Sudocrem and Cavalon. Mediderma is the current favourite that most of us are probably using, but it's brilliant for any areas. If someone's not just incontinent, but if they're overweight, can be used to help with moisture lesions as well. Applying creams, an often really misunderstood area. When we're young and we're applying our moisturizer to our face or our body, we're probably just rubbing all over and, you know, not really thinking about how we apply creams. So creams that can be used as a soap substitute, literally you would just use it as though it was a shower gel. So you have your warm flannel, your wet flannel, and you apply a little bit of soap of your Epimax or whatever you're using, and you just use it like you would do a shower gel. Now, obviously, it doesn't have that pleasing effect of going all lathery and soaping up, but it will be doing just as good a job. And there is actually no requirement to wash off this cream. Obviously, if you're washing someone that's had their bowels open and things like that, then that would be, you'd have to take that into consideration. You make sure that person's dry, not necessarily rubbing. You might just have to pat that person's skin dry if their skin is particularly frail. Make sure you're using a soft towel. Make sure everywhere is dry before you then apply any more moisturizing creams. So when you do apply your moisturizer, and this is the big thing that a lot of people get wrong, a lot of people will apply moisturizer and then use a sort of circular motion to rub it in. Please don't. It needs to be applied in a downward motion to avoid damage to hair follicles. So hair follicles generally grow down. And also with particularly frail skin, if you're rubbing it in a circular motion, then it can also cause friction damage. So really important. Yes, it takes a bit longer, but actually it's probably more pleasing for that person as well. Then a time gap of around 20 minutes should be allowed before applying barrier creams. So if you know you're going to have to apply a barrier cream, you don't necessarily need to apply a moisturizer to that area. So say it's under the breasts and they're already quite moist, then that's fine. You can apply that Mediderma or whatever barrier cream you've got at the same time. But if you're applying it where you've moisturized, you must wait 20 minutes for the moisturizer to be absorbed. Otherwise, the barrier cream won't do anything. And making sure you use the correct amount. Certainly with Mediderma, it's a very small amount. A pea-sized amount, I think they say, does 15 centimeters squared. So a little does go a really long way. And then what we've mentioned earlier, creams need to be fully washed off before you're applying another layer of cream. Otherwise, you're just literally applying cream after cream after cream. And we've certainly seen cases where this has caused hair follicles to become blocked, and that leads to an infection. And obviously, you know, it might sound simple, but always check and follow your guidelines or your prescribed instructions, because just what we're saying here might not actually be what's prescribed. So you must go by what the prescription says. And any acute creams. So if somebody is prescribed a steroid cream or a fungal cream for an infection, again, you must wait a 20-minute gap at least between, you know, applying your moisturizer and your acute creams, because otherwise, you know, it's just sitting on top of the moisturizer and it never gets absorbed. So another really critical area that sometimes I think does get forgotten, and that is nail and hand care. So nails, you know, long, jagged, dirty nails, not only can they cause damage to the skin, they can cause skin tears, they can cause rashes, they can cause grazes, but they will also introduce bacteria into open and current wounds. So it's really important that as part of your everyday personal care, as often as you can, you're checking nails, especially with people that are cognitively impaired, because, you know, they don't understand. They know they might try and help during personal care. They might have feces under their nails, urine, dirt, anything. They could have been doing an activity. They could have been doing gardening as an activity. You know, we need to make sure their hands and nails are clean so they're not introducing bacteria into wounds and into the skin. So, excuse me, what about when a wound does actually occur? So Care homes, as standard, we should all have a basic stock of dressings available. These should be generally a simple adhesive dressing in a variety of sizes. So anything from a tall one to, as you can see there, there's some really long ones, some steri strips as well. Steri strips are useful when you've got skin tears and things like that. But that will enable you to have timely to be able to timely dress that wound. Even in residential settings where you will need to refer perhaps to district nurses, you're not going to leave an open wound bleeding or open to the elements or bacteria. So we should always make sure we've got a basic stock of dressings available to use. We should not be applying prescription creams to someone who's not prescribed them. And I don't know about everybody else, but over the years of my career, I've most commonly seen people keeping hold of things like Inodine and using that for someone that is not prescribed for. It is actually a specialist dressing that is a prescription only dressing. So therefore it should only be used. We have to consider allergies and things like that, and that is it the right dressing for that wound? So it shouldn't just be applied. Wounds should be photographed, so really important. And yes, there will be exceptions to this. If someone's got a wound that is bleeding profusely, you're not going to just hang on and say, hang on, let me get my phone or my camera, I'll take a picture. Does need to be some clinical judgment here, but you do need to take a photo of that wound. Measurements as well. Quite a lot of dressings actually have a little measurement tool on the packet that you can use, or you can have, like in the picture down there, disposable tape measures. Some people have even got really fancy apps that will measure it for them and take the picture at the same time. But really important to do both, because it's basically a tool so you can monitor if things are improving or getting worse. And then a really important one, when you're dressing a skin tear, if you can see in the bottom right hand corner, there's a dressing there with an arrow on. Basically, that is showing the direction that you would need to take that dressing off. And that means it's not going to disturb the lie of the skin. So particularly in a skin tear where you've replaced a flap, it just shows you which direction. If you were to do it the other way, the chances are that skin flap would come away again with it. And then you're just ruining any good work you've already put into place. So documenting wounds. So what do the NICE guidelines say? As you all know, we are governed by various bodies, and we do need to make sure we're doing things correctly. So risk assessment and skin assessment. So initial assessments. So we use formal risk assessments. Where I work, we use a Waterloo score, which is there. We're all on a computer, so we don't have to physically sit down and actually go through this table. We can just input the information and it gives us a Waterloo score. So that gives us a risk to that person. And then skin check records. So body maps. So we need to have a clear picture. Generally, most of you, I'm sure, will have all seen in some form or other the picture on the right hand side there of the front and back of a person. And you basically need to very clearly document where that wound is. Alongside that, you'll also need to have a plan of care, review frequencies, and then documentation and evidence actually that those wounds are being reviewed. So when we're talking about pressure ulcer assessments, again, we go to the NICE guidelines. When we're documenting, it says that we must categorize the wound, what we're actually using. We quite like the apples one, just as a nice little acronym. Uses apples to sort of, as a bit of a prompt really for the different wounds. There's different pictures readily available on the internet. Everybody's got access to the internet these days, so should never be a problem really. Measuring, we have to document again, and the difference this time as well with pressure wounds is generally they also want a depth. So this is not always going to be appropriate if you've got somebody that's just, you need to consider things like pain and things. So you can't necessarily go poking filaments into wounds if it's going to create issues. But certainly you need to make sure you are measuring the area, especially with pressure wounds, as we all know and we're all aware, they tend to get worse before they get better once they get to a certain stage. So we need to have really good, robust evidence. And then there we go, depth and characteristics. So we also need to talk about the undermining. So with a pressure ulcer, just because what you see might be very small, it might be less than a centimetre, but actually when you stand back and look at that area, there could be a large red area around the outside, and chances are that's the wound undermining, and that's the true size of the wound. So again, very important to take pictures and to use your clinical teams as well. If you're not too sure, use your wider team to, guys, what do you think? Is this undermining, or am I seeing things? Because quite often, sometimes we can be. We need to document the type of tissue present. So we need to talk about slough, necrosis, granulation, epithelialization. We need to really describe what we're seeing. And tissue viability, obviously, if you've got a pressure wound, if it's, not improving, you're concerned in any way, then yes, do refer to the tissue viability service. And generally, we find they're really good. They come back really quickly. They'll ask any questions. They're a great team, and we've always found them really helpful. And they're also really understanding. So, they're not going to, obviously they've got a duty of care, but they're not going to judge the fact that you've sent them 3 referrals in a week. As long as you've got rationale and you've got a history as to why that person has that wound, they're really good. Then obviously we need to discuss, to think about care planning and what we're going to do as preventative actions. Each person, each wound should have its own individualized care plan. This can be in a variety of ways. So it can be an actual tissue viability care plan, or it can be part of your body map. You can have, a description of your wound and then the actual plan of care in your body map that you can then stick to. But yes, we do need to make sure that is very tailored to that person. Just because one person's pressure wound is responding a certain way doesn't mean that the next person's will be the same. So it needs to be individual, tailored and holistic to that person. And it needs to take into consideration, a person's mobility, a person's compliance. Does that person go to bed? Do they not go to bed? Will they allow you to reposition them? Will they not? Things like that. Then we need to have a very clear idea of what we're going to do repositioning wise, and this needs to be in all relevant care plans, and it needs to be adhered to, and it needs to be checked. So we need to take some responsibility for ensuring that actually what we're asking our staff to do, they are actually doing. If they're not, why are they not? It might be that they're struggling and they just haven't told you that that person's being particularly aggressive, or they've asked not to. So it's really about team communication. Equipment, so the most common ones, for example, are obviously your mattresses. So you might see the most common is probably a standard foam or a high spec foam mattress, but also, we'll be talking about things like airwave mattresses, specialist cushions, or heel offloading devices. I've seen wedges used before for people that are bedbound to help keep them in a certain position. And then nutrition. So, it's always prudent perhaps to be able to monitor for a period of time what that person is eating and drinking, because it is such a critical part of wound healing, really. So food and fluid charts just for a period, even if it's just a short period, so you can be sure in your own self that person is getting a well balanced nutritious diet, and also look at things like their MUST scores, and could they do with some high protein meals or high protein supplements just to aid in that sort of healing. So what do we document? So we document tissue type. So we've talked about that. We need to try and be quite specific, because quite often you'll see a wound where it's starting to heal, but there's a little bit of slough or still around the edge. So if you see that, make an estimate and say, like I've got here, 80% granulation, 20% slough. You can go into more details and say, wound mostly granulating, but to right side outer edges, there's still a small amount of slough present. Talk about the wound edges and the surrounding skin. So we're talking about undermining and tracts, but also quite often you might see signs of some maceration. So maceration is basically skin that's been damaged by moisture, tends to be on the edges of wounds, or when you've got like leg ulcers and edematous legs, you'll see skin become macerated because of the fluid. Color of the wound, such an important one, because it can actually help you to identify infection when everything else is not showing you that. So like the most common one really is not the wound as such, but cellulitis. If someone's got red swollen legs, and they're, the redness would be the first thing that would attract your eye to that area. All right. And then, yes, we need to make sure we actually identify the wound, what it is within our documentation. So we would state, grade 2 pressure sore, moisture lesion, skin tear, whatever it might be. We need to document the location. So obviously you've got your body map where you would put that, but then it's also important in your written notes to also document. So you would say left buttock or left breast, right arm, mid right back, things like that. Comment on any exudate and if there's any odor. So not always going to be relevant to some wounds, but certainly with your pressure ulcers, your edematous areas, your cellulitis, things like that, you would need to comment on the amount. So and simply just put, mild, moderate, large amount, and then just think about the odor, because again, odor is a good sign of infection. Pain levels, really important, pain levels. And this isn't necessarily just during dressing changes either. This can actually be, every day for the person. So comment on both. But certainly during dressing changes, because it's such a simple thing you can rectify. Because if someone is experiencing pain when you're changing that dressing, speak to the GP, get something prescribed PRN that can be given 20 to 30 minutes before you plan to change that dressing. Anything that can make that person's life just that little bit more comfortable is what we need to do. And if you've got the documentation and you take it to your GP, there can be no argument. Like we've said before, measure. Certainly the most important one is length and width, and then we do need to consider depth as well. And it just says there to use a validated technique, so photography. So, we always say to take pictures as often as possible. We like to take pictures at Evolve on every single change, because it's surprising how something can change even in a day. And then obviously using a measurement tool. And then basically entries for wound care always need to be, your documentation always needs to be in real time. So where possible, and we fully understand that emergencies can happen and our time is often, we're dragged away to do other things, but where possible, we need to complete our documentation during or immediately after the procedure, because it's fresh in our mind. We won't forget then, it's fresh there. And we can also, if there are any issues, it also means that we can actually then we can escalate it to a GP really quickly, or a district nurse, or whoever needs it, rather than thinking, oh God, I've forgotten about it, and at 5 o'clock in the evening it's too late to get through to a GP or a district nurse, and you're really worried about infection. Then you go down the routes of out of hours, and obviously their time is very pressed as well. And lastly, every single entry needs to be signed and dated with either a legible signature or an electronic identifier. So if you work on computers, generally you're going to log in under your own login anyway, so that will automatically sign that. If not, you need to make sure that your signature can be understood, and you need to date that wound. All right. So then just to finish, I've literally just got some examples here of just some made up wounds, just a few different ones where, at times it can seem, oh God, I've got to document this, it's so long, but actually the more you do it, the more you follow protocols and regulations, the easier it does get, and it becomes second nature to document. So you're all going to get a copy of this handout anyway, so you can, look at these ones in your own time, use them if you want to when you're documenting wounds going forwards. I don't mind, it's absolutely fine. But yeah, good documentation. So as you can see there on the left for the one on the 21st, it talks about the colour of the wound, yellow with red edges. The tissue is presenting as 100% slough at the moment. The surrounding skin, there's red edges to it, fading to a dark pink. But obviously we've also noted there that that area is at risk, so we need to be really careful. No exudate. Patient expressed some mild pain during change, so I might want to look at that later on. Have they got a PRN, or do I need to speak to the GP on the next round, or if it's more urgent, then give them a ring. The size is very clearly documented. It's unstageable because we've still got slough present, so we've noted that. There's the location management. So in this case, there was some tissue viability guidelines that was actually detailed in that person's care plan, and that's what we're following. And we've chosen to review that on a Monday, Wednesday, and a Friday. And we've also taken pictures for records. Okay, and then again, much the similar. We tend to follow a very similar sort of protocol, really, but with a skin tear, it might be slightly different because we're talking about other things. So this was a new skin tear that was obtained to the left hand. We knew how that person got it, so always important when we know how the person achieved that wound, always important to document it because it just helps from auditing purposes and to see what could have been done better, what could we change, how can we improve things. The wound was bleeding at the time, so we applied pressure. We replaced the skin flap back over, always important when you can, and if that person will allow, because it can be painful, to replace the skin flap in place, because often it will then heal very well rather than ending up with a large area with no outer layer. No signs of infection noted. I wouldn't expect there to be at this point anyway, because it's the first one. The size is clearly documented. I've applied an adhesive dressing. Now, if I was in a residential home at this point, I might refer that to the district nursing team for them to do, which I would also document there. And I've just made note there that I've actually used an arrow to show the direction of removal. Always important to document that too. Set a review date of 5 days. Where possible, it's always a good idea to leave dressings in place as long as possible, because then they can do their job effectively. And we've taken a picture. And then finally, just with the kissing moisture lesion. So kissing moisture lesion is a moisture lesion that typically you find on a sacral area where it mirrors on both sides of the buttocks. So I've just put there mild currently, redness to both buttocks. Damage is mirrored, so I've made note that that's why I've said it's a kissing moisture lesion, because it's mirrored on both. No odor present, so that means hopefully there's no infection there, there's no real maceration. It is blanching when tested, so really important to test if a wound is blanching. If it wasn't blanching, then it would be more likely to be pressure damage. No blood or exudate present, no heat or clinical signs of infection. So we're just working through very similar things every single time. Pain noted by the patient to be mild. So again, something to consider. Surrounding skin dark pink in colour and vulnerable. Size, I haven't actually put a size there. So that would be then picked up on through clinical reviews and audits that actually that wound hasn't been sized correctly. It might have been that we've not been able to, and that's absolutely fine. If you're going to do a wound dressing and that person is already irritated, say they've had a fall and they're really agitated because they want to get up off the ground but they're bleeding and you need to dress something, it might not be appropriate to measure it at that time. That's fine, but make reference to it in your documentation. So it's not a problem as long as you've got a rationale. And again, same with picture. If you can't take a picture for that very reason, if a wound's bleeding, you're not going to suddenly just say, oh, I need to take a picture, I need to measure it, I'm going to let it bleed everywhere. You're going to wait and do that at a later date, and that's absolutely fine. So it's just about having confidence in what you're documenting. And then I've just got some useful, really, really useful websites for you there, basically. So basically nice guidelines. Most of the nurses on this call will know all about the nice guidelines, but obviously I'm quite aware that there are people on this training that aren't a nurse, but actually it's really helpful if you Google and go onto this website. It pretty much tells you anything and everything about any aspects of clinical care, so it's really good. Just in case anyone's interested in the APPLS and acronym we use for pressure ulcer staging, I've popped that there as well. And then just the tissue viability website. The tissue viability website itself is really useful, has a lot of training tools on there, a lot of information and a lot of pictures and things like that. And that's it, guys.